Hey everyone, Dr. Maynard here. Excited to talk to you today about the EPOC pre-hospital lab system, which is going to allow us to both diagnose and treat certain conditions even before we bring the patient to the hospital. This is a pretty exciting time. We are one of the first departments in this area to roll this out, and a lot of work and effort has been put into rolling out this system. So we are excited to roll out. The goal of today is to help you understand what to do with these labs once you get them. We're going to be going through the best EMS EPOC protocol, and we'll walk you through that. Just big 30,000 foot overview here. We've got three parts to the system. We've got the host, which is the kind of iPad or phone reader. The reader below actually does the analysis, and then the card. So you've got the host, the reader, and the card. The card is where it goes into the reader and blood sample is applied. And you can get up to 31 different lab values, which is pretty impressive. This can be stored at room temperature, doesn't require refrigeration. And we're going to be focusing on just the five different labs that are in our protocol. But it's a pretty powerful device. All right, objectives. So today we want to become familiar with the common pre-hospital lab abnormalities. So basically, when we get the diagnosis, and then how we use those labs to guide our treatment. We're going to be using the best EMS EPOC protocol. We also want to learn a little bit about false positives and false negatives. So no tool in this world is 100% accurate. And so there are times where the result doesn't make sense with the clinical picture, and we want to paint that accordingly. And then also we want to prepare you for the EPOC pre-hospital lab test that's going to be coming up. So there is a multiple choice question test that is going to be distributed, and everybody will need to pass that test before using the system. All right. One note that this lecture will not cover the EPOC operations, such as how to log into the system, connect the Bluetooth, print out, collecting the sample, how to give it, how to deal with improper samples, how to calibrate. All of that will be covered in separate training. There is a great video, which I've linked here, and we'll give you a link to, that will help you understand the operation of how to actually get the results. Another note, don't worry so much about memorizing these lab ranges. There's a lot of ranges, and I want to make sure that you guys know that when a range is within range, when you get a result that's in range, it'll show up as normal. If it's outside of the range, it'll be yellow. If it's critical, like way outside of the range, then it'll show up as red on the screen. And so you'll know when a lab is abnormal. All right, pre-hospital labs. The question I ask myself is, are we opening a can of worms, right? Lab work is incredibly complicated. There are both values that are high and low. These systems are very complicated. The human body is very complicated. And so when we give paramedics and EMTs this new tool, we want to make sure that we are teaching them how to use it. You can see here, this is a treatment algorithm for hyponatremia. So just one electrolyte, sodium, and it's not even high, it's only low here. And look at how complex it gets suddenly. So remember, labs are a tool. Just like any tool, they have their limitations. Remember, you got to know how to use the tool in order to use it effectively. In other words, don't be like this guy. Use the tool properly. Remember also that lab work is only a part of the overall clinical picture. Look at your patient. The good news is you guys already know how to treat patients. And so when the lab work disagrees starkly with the patient's presentation, remember that you may have a false positive or false negative for that lab value. So in other words, treat the patient, not the labs. All right, so these normal ranges that we have for every individual lab, how do we get those ranges? Well, basically, they sample a population, and for the healthy population, they take 95% of those, and there are some outliers on each side of that bell curve. But basically, these normal ranges are just from doing samples of the population. And those that are healthy, they have a standard range. Now, this can vary by geographical location. So if you're in Africa or Mexico or the United States, you may have different lab values based off of a different population. All right, so what can it do? Basically, it can do two things. It can measure directly blood values, such as sodium, potassium, creatinine, but also it can calculate certain other values based on that. So here we have the EPOC menu, and you can see that it does quite a bit, few different things. We have blood gases. We'll be doing just VBG. We can get a lactate. We can get a full metabolic panel. So these are all your electrolytes and your renal function. You can also get a hematocrit and then calculate a hemoglobin based off of that. And you can see here when it says C hemoglobin, that means it's a calculated hemoglobin. And a bunch of other things that we won't worry about too much, like GFR, glomerular filtration rate. The 5 most important labs we're going to focus on, according to our protocol, are going to be as follows: sodium, potassium, calcium, hemoglobin, and lactate. And we're going to cover those in order. All right, just a reminder that units matter. Remember that when you're measuring, for example, sodium, you're not measuring all the sodium in the entire body. That would be impossible to do. So what we actually remember, what we're really measuring is just concentrations. And so remember, a concentration is a mass per volume. And so I always think about like Kool-Aid, right? So if your Kool-Aid was to add 1 liter of water and 1 scoop of Kool-Aid, that would be the proper concentration. But if you added 2 scoops of the Kool-Aid, that would be highly concentrated. So the volume didn't change, but we changed the number of particles or the mass that we put in. Now, conversely, we can make it dilute by adding more water. So instead of 1 liter, we do 2 liters of water and 1 scoop. And you can see how this works. But remember, when you're looking at all of these units, you can see here, like for example, potassium is in milliequivalents per liter. And so it's always a concentration. So it's a mass per volume or particle or millimole per volume. All right, this is the best EMS EPOC protocol. So you can see there are indications and then there's the different lab values, and we only are going to focus on 5 lab values. And this may not seem like a lot, but it can get really complicated really fast. So we're going to start with indications, and then we'll just kind of run on down the line. So starting with the indications, I'm going to give you an indication such as sepsis, and then we'll talk about the key labs that we might expect to find abnormalities on, and we'll just kind of go down the list of indications. So for sepsis, I would expect that the lactate might be elevated and the pH might be low. Lactic acidosis is a metabolic acidosis. It causes a lowering of the pH, and so we'd expect to find a low pH number. All right, syncope. What kind of things can cause syncope that we could find on the labs? Well, what if you had a low hemoglobin or anemia? What if you had an abnormality in your electrolytes? Could be high or low, and that could also lead to syncope or an arrhythmia. Same thing with general weakness. There's a lot of overlap between syncope and general weakness, so we can find that, if you're anemic, you might be generally weak. If your potassium, sodium, or calcium are off, you could also have general weakness. DKA, we know by definition, it's a diabetic. You have ketones and it's acidosis. So we might find that. Also, you could have hyperosmolar hyperketotic state, or HHS. So we're going to find an elevated glucose, a low pH, and a low bicarb. And what is BE? B is a base excess. So base excess tells you how much base you have in excess or how alkalotic you are than what would be expected. Now, in DKA, you would have a negative base excess, meaning that you don't have a lot of excess base, if that makes sense. I know it's a double negative, but when you think about it, it makes sense. All right, cardiac arrest. What kind of lab values would we look out for that? Hemoglobin, of course, your electrolytes, right? You think about hyperkalemic patient, right, that went down because of end-stage renal disease, maybe a missed dialysis. You see a dialysis fistula, and you're starting to think about, hey, maybe their potassium's high. We can actually check that now and see that they've got a potassium of 7.5 or something high. And then go ahead and treat accordingly with your calcium, your bicarb, and move forward. Now, how would it apply to trauma? Well, for trauma, we look at hemoglobin, right? If you lost blood internally or externally, we might find that the hemoglobin is low, and that would be nice to know. Calcium. Why is calcium important in trauma? Well, this becomes more important when we start to give blood transfusions, because as we give blood, there is a preservative within the blood that sequesters calcium. The problem is that when we give blood, it's really calcium poor, meaning it doesn't have adequate calcium in the blood. And so we're delivering this, and it basically dilutes the total calcium in the patient. And so calcium can start to go down if you're giving too much blood. I don't think it'll be much of an issue for us unless we're giving several units of blood to a patient. But just remember that if you're giving repeated blood transfusions, that eventually you're going to need to replace calcium. So it would be nice to be able to check that to see if that calcium level is going down. Medical hemorrhage, what is that? This is your vaginal bleeding, your postpartum hemorrhage, your GI bleed, or maybe even a dialysis fistula that, ruptured after treatment and they couldn't control the bleeding. And so medical hemorrhage, this would be somebody that we would want to check their hemoglobin. And then if we're giving blood transfusion, of course, check calcium levels because they may be getting low. All right, undifferentiated Brady or tachycardia. We might look at the electrolytes, of course, the EKG. Dehydration. We would look at things like the sodium, the chloride. Those are both typically going to be concentrated or high when somebody is dehydrated. And we also will look at their creatinine and notice that it's probably going to be elevated because the kidneys are not getting rid of creatinine. So it tends to build up in the blood and would be elevated. Undifferentiated altered mental status is a big one, right? Lots of things. So it could be hypoglycemia or hyperglycemia, could be high or low pH. We could look at their CO2 or bicarb. We could look at their base excess, their hemoglobin, their potassium, sodium, calcium. All of those could be abnormal. Also, sometimes we may need to do an emergent transport for a hospital that they've got inclement weather, they've got a delay, they got a significantly critical patient, and they ask us to transfer. And we may need to check, for example, if somebody was a trauma patient that needed to go to a trauma center. So we're transferring from one, like let's say a freestanding ER. We may need to take them and check their hemoglobin. So we would note their initial hemoglobin, let's say it was 8, and now their hemoglobin is dropping down to 7. Well, now they would meet criteria to get a blood transfusion. And so it would be good to know about that and then hand that off to the receiving hospital. Also, one of the indications is paramedic distraction. So if you feel like the patient may have lab abnormalities, we can check. And just remember that once you get the labs, now you've got to explain them. And so please use your discretion when doing that, but you know that you can perform that lab work if needed. A couple of reminders here that the venous sample is preferred over capillary. We do have the ability to do both venous and capillary. We're not going to be doing arterial samples because sticking a needle into the artery, number one, is painful and also has some risk associated with it. So we're not going to be doing ABGs. We'll be doing VBGs, which are just as good for our intents and purposes. During a cardiac arrest or if a patient is intubated and sedated, we can do a femoral vein draw where we would stick a needle into the femoral vein and draw out blood if we were having trouble getting the blood sample. By the way, we can only take blood samples, whole blood samples. We cannot take IO aspirate because it will not work in the EPOC system. All right, remember that the samples need to be run within 1 minute. Actually, I think technically for the EPOC, it's 30 seconds. And so you want to have your sample ready by the time it is ready to accept it. All right, back to the protocol. We're going to start with sodium. Now we're going to get into the actual lab values that we're checking. So sodium can be high or low. When sodium is low, we call it hyponatremia. So what are the symptoms? We might find that the patient is confused. In fact, this is the hallmark of low sodium. When somebody has low sodium, oftentimes they're confused. This is typically an elderly patient. There are certain medications that can cause this. Eventually, they may become ataxic. And then eventually, if it gets bad enough, you may even develop a seizure. This is a rare cause of seizures, but it can happen, hyponatremia, and then eventually coma and eventually death. So what are some causes? Well, we have SIADH. This is a syndrome of inappropriate antidiuretic hormone. So the kidneys respond to ADH, and basically they do not, or they do not diurese, and so they're going to hold on to water. And if you hold on to water, wouldn't that dilute the sodium content in the blood? So that's what SIADH is. If somebody drank too much pure water without electrolytes, that would also dilute the sodium in the blood, causing low sodium levels. There's certain renal diseases, and then of course CHF is volume overload, and if that volume of the plasma is water rich and sodium poor, of course that would be considered hyponatremia. All right, so what do we do? Well, if the sodium level gets below 125, which is a pretty low sodium, then we're going to go ahead and give IV fluids. Now, IV fluids have a higher concentration of sodium, and so that actually will bring up the sodium level. But it's important to note that we do not want to correct the sodium too quickly. So remember, we've got a low sodium, less than 125. If we give normal saline, it will raise the sodium, but we do not want to raise it too quickly because it may lead to ODS, or osmotic demyelination syndrome. This is a terrible condition. It can actually lead into what's called central pontine myolysis, which is when the patient has severe demyelination, or basically a rupturing of the myelin sheath in the neurons of the brain. And this can actually lead to the patient having what's called locked-in syndrome, where they're completely consciously aware, but have no way to interact with the outside world. It sounds like something out of a Stephen King novel. All right, sodium concentration in the blood is 135 to 145. So we can see that above, we're going to treat if it gets below 125. If it's 130, we'll note it. It's outside of the range, but we're not going to treat yet. It's only when it goes below 125 that we're going to go ahead and give those fluids at 75 mLs per hour. And this is specifically normal saline we're talking about. And remember, normal saline does have a higher concentration of sodium. So you can see that normally in the blood, it's 135 to 145, but normal saline is actually much higher concentration. It's 154. So you can see that if we were to add normal saline to the blood, it would actually cause that sodium to rise because it's a higher concentration. And remember that you can cause ODS with correcting hypernatremia or hyponatremia, but it's more likely to be caused when you're correcting hypo. Basically, if the sodium's low and you give saline, you could cause ODS. Whereas if the sodium is high and you give saline, which is also, as we'll see here in a minute, that can also cause ODS, but it's less likely, less of a concern. All right, so speaking of hypernatremia, the sodium is too high. What are the symptoms? Well, exactly the same. The brain neurons do not like to have a shift in the osmosis or the osmotic gradient. And so when sodium gets too high or too low outside of the cell, you can get swelling or shrinkage of those neurons, and it can cause confusion. So confusion is going to be the first sign that you see. And then, of course, ataxia, seizure, coma, and death eventually. All right, so what are some causes of a high sodium in the blood? Well, dehydration, right? Because you're losing pure water and it leaves a concentrated solution. Think about that concentrated Kool-Aid. Renal disease, they cannot get rid of their solutes, and so they tend to accumulate in the blood. Diuretic overuse, if you're getting rid of water, it can cause hypernatremia. And excessive body water loss. So think about your vomiting, your diarrhea, your excessive sweating and exertion. All right, so when the sodium gets over 145, that's a pretty high sodium. We can go ahead and give fluids. We can give it a little bit faster. If you see here, previously, we're only going to give for hyponatremia 75 mLs per hour, but now we can give 125 if the sodium is high because there's less of a risk of ODS. All right, so what are some pitfalls when treating sodium? Well, or actually taking the sodium labs. So how can we be fooled? All right, let's do a case. You start an IV with normal saline running, and the patient has a GI bleed. So you're using the EPOC system to check the hemoglobin level. And when you run your results on the hemoglobin, this is what you see, a hemoglobin of 3.5. That's really, really low. You see a sodium that's high, 150, and you see a chloride that's also high, 150. So how do you explain this high sodium and chloride? Now, remember, in the blood, the sodium should be 135 to 145. But in saline, it's 154. So how do you think that these numbers are explained? The results that we got, well, basically what happened is the saline got into our sample and diluted our sample. So we get a high sodium and chloride because that's what we were running in S, and we diluted the hemoglobin. So we made the hemoglobin lower because we added too much saline to the sample. All right, so what do we do? Well, next time we're going to draw and discard at least 10 cc's of blood from that line if there was anything running through it, and then redraw and resend your sample. All right, so next section, now we're going to talk about potassium, and typically we are only worried about a high potassium. So potassium, a critical electrolyte in the body, and when the potassium is low, what are the symptoms? Well, normally general weakness, not unilateral or focal weakness like a stroke, but generally weak. These patients, if their potassium gets low enough, they can become very, very weak. They can go into arrhythmias. All right, so what are the causes? Well, excessive body water loss, so vomiting and diarrhea. You tend to lose potassium in both the vomit and the diarrhea, and also diuretic overuse and certain renal disease. Now, the treatment is just to give potassium back. So if the potassium is low, you just replace the potassium, and you can do that by mouth or IV. Of course, we are not going to be doing that. Actually, replacing potassium can be pretty dangerous if you give it too fast. You could literally kill the patient. In fact, when criminals are executed on death row, the way they kill them is by doing a potassium injection. All right, hyperkalemia. This is where we need to focus our efforts. So when the potassium is too high, this is where we're going to focus. All right, so what are the symptoms? Well, they can develop muscle cramps as an early symptom, eventually arrhythmias, and then become bradycardic. And what are the EKG changes that we see with hyperkalemia? These are things that we know from our paramedic school. So the first thing is you start to lose the PR interval. You can start to get peaked T waves. And remember, these are going to be very symmetric and peaked. And the QRS will eventually widen and then finally widen so much it becomes a sine wave. Those are the signs of hyperkalemia. And what are the causes? Well, we know that end-stage renal disease, they can't get rid of potassium through the kidneys, and so it tends to accumulate, especially if they miss dialysis. There are certain medications that can cause elevated potassium, such as spironolactone. This is what's known as a potassium-sparing diuretic. And you'll see that a lot of the cirrhotic patients will be on spironolactone. It's also known as aldactone. And then, of course, we have our ACE inhibitors and our ARBs. Remember, ACE inhibitors are ending in pril, so lisinopril, captopril. The ARBs are the ones that end in sartan. So think about losartan or valsartan. And all of these medications can cause high potassium. So look at the med list and then consider maybe that's what's causing the patient to be hyperkalemic. Of course, you got a patient who's in rhabdomyolysis. Now, you won't know that for sure because we don't have the ability to check for a myoglobin or CK in the EPOC system. But if they were exerting themselves on a hot day, not drinking enough fluids, you may be able to see that their creatinine is elevated, but their potassium might be elevated, and that might fit the clinical picture for rhabdomyolysis. Severe burns can also lead to hyperkalemia. All right, so how high is too high? Well, if it's above 5.5, then we can consider treatment. All right, so what is the treatment? Well, it kind of depends. If the patient is in cardiac arrest and we get back a high value, we're going to follow the hyperkalemia protocol. If they are awake and talking to us and they have no history of renal failure, but now we see their creatinine is elevated, which indicates renal failure, then we would go ahead and treat that hyperkalemia. Now, if the renal function is normal, meaning less than 2, and that's just where we decided to put the cutoff. It doesn't necessarily mean that that's normal for the patient, but that's where we decided to put the cutoff. So if the creatinine is less than 2 and you get a high potassium, something's not making sense there. So why would the patient have a high potassium and a normal creatinine? It could be lab error or what we call hemolysis, and we'll explain that a little bit. But if you get a high potassium and the renal function is normal, the next step is to repeat that test because it's probably a lab error. And we'll talk about this in detail in just a minute. If the repeat is still high, so now you've checked it a second time and it's still high, greater than 5.5, then at that point you would go ahead and treat for hyperkalemia. And just as a reminder, there is the hyperkalemia protocol there, which of course, if the patient is awake, we use calcium gluconate. Calcium stabilizes the cardiac myocytes and prevents them from going into the severe arrhythmias. Sodium bicarb is going to help decrease the potassium in the serum and push it intracellularly, and albuterol does the same. All right, so speaking of the pitfalls of potassium, how can we go wrong when checking potassium? Let me give you a case. Your patient complains of vomiting and diarrhea. She's a difficult IV stick. So you finally get the blood sample after a long, arduous process of checking and failing. Um, and you notice that the EKG is normal, her vital signs are normal, and your EPOC potassium comes back at 9.0, which is incredibly high. Most people would die or be in an arrhythmia with a potassium of 9.0. And you also note that her creatinine or her renal function is normal. So why would that be? What is causing her hyperkalemia? Well, in this case, likely there's hemolysis, meaning those red blood cells burst open and spilled out all of their potassium. And that's why the analysis seems like it's a high potassium. The true potassium of this patient is not actually elevated. All right, so what do we do? Well, we need to redraw the sample and rerun with a new EPOC card. All right, let's review why this is the case, because it's hard to remember these things without knowing why, and I'm a visual person. So if we look that this is a diagram of a cell, not a very good diagram, but this is a cell, and we can see that there's different concentrations of electrolytes inside the cell, or what we call intracellular, and outside of the cell, or extracellular. And we see that with potassium, it is very high inside the cell, but very low outside of the cell. Now, remember, normal potassium is like 3.5 to 4.5. And so that's pretty low. And then we think about sodium. Remember, now that's high outside of the cell. And that is normally like 130, 140, right? So it's much higher outside of the cell. Now, remember, just as a review, we never measure inside the cell. When we take a blood sample, it's not measuring inside the cell. And just think about why. Well, it'd be impossible to sample inside every cell of the body. What we do sample is outside of the cell. These ones out here, the extracellular fluid is what we're sampling in the blood. And that's where, when we get lab values, this is what it represents. But just remember, these ions go back and forth over the membrane constantly. In fact, that's how our muscles contract, is by sending sodium in to the cell, potassium out of the cell. If you remember, this is your depolarization and repolarization. And so just remember that potassium is high inside the cell if you don't remember anything else. So if we leave the tourniquet on, eventually all that pressure will cause this fragile red blood cell to open up, and all this potassium spills out into the extracellular fluid and then causes a falsely elevated potassium. And that's exactly what happened in this scenario here. All right. So remember not to leave the tourniquet on too long. All right. So what are some causes of hemolysis or a falsely elevated potassium? Well, prolonged tourniquet time. You could have excessive suction in the syringe that puts a lot of pressure on those fragile red blood cells, spills out all the potassium. You get a falsely elevated potassium. You could have continuous clenching of the fist. We ask the patient to pump their fist. Remember, once they pump it, right, they relax. When you do the blood draw, they shouldn't keep their fist clenched. And then also forceful shaking of the blood, but I don't think we'll be doing that because it's not necessary. We have to put the sample in right away. All right, now moving on to second or third to last, calcium. Calcium, we're really only worried about it when it's low. High calcium does cause problems, but we don't have a solution for that pre-hospital. Basically, we're going to focus on low calcium. All right, so also known as hypocalcemia. So what are the symptoms? Paresthesias, or that feeling of pins and needles. It usually affects the hands, the foot, the perioral region. They can actually lead to uncontrolled spasm or tetany, and eventually seizure if it's bad enough. What are the causes? Well, if your parathyroid function is too low or hypoparathyroid, that could cause it. Now, why is that? Well, PTH or parathyroid hormone is responsible for calcium uptake into the system. And so when you have low parathyroid function or low parathyroid hormone, that would cause low calcium because you don't have the hormone that brings in calcium through the digestive tract and also from the bones. Now, what could cause hypoparathyroid? Well, if you had your thyroid removed recently, the parathyroid, as the name implies, is right next to the thyroid. In fact, surgeons tell me that it's basically indistinguishable from the thyroid. So you've actually got four parathyroid glands, and they sit two on top, two on bottom, basically right within the thyroid tissue. So when they remove the thyroid, they can't always spare the parathyroid. And so oftentimes somebody will have a recent thyroidectomy and then they'll come in with spasms, paresthesias, right? And then we start to think, hey, I wonder if this patient has low calcium. Of course, vitamin D, we all know, is involved in calcium absorption. And so vitamin D deficiency could be the issue. Malabsorption, so think about like all of your GI issues, Crohn's disease or celiac disease. These are the patients that may not be absorbing calcium properly. And pancreatitis, specifically acute pancreatitis, can cause low calcium because it sequesters the calcium and causes it to precipitate as the pancreas is inflamed. That's kind of a rare cause. All right, so as you might think, if the calcium is low in the blood, we can just give them calcium. Well, how low does it have to be? Well, we use what's called an iCal or an ionized calcium. And so less than 1.14 is our cutoff. And we're also going to ask that if the patient is low, we also have symptoms. So what kind of symptoms? Well, all these symptoms above, paresthesias, spasms, tetany, um, and or have a prolonged QTC. So we know that when the calcium gets low, that it can cause prolonged QTC. Well, how long? Well, greater than 500 milliseconds. If they meet that criteria of having symptoms or prolonged QTC plus a low calcium, we're going to go ahead and give them 1 gram of calcium gluconate, not calcium chloride. Remember, that's only for cardiac arrest, but calcium gluconate. All right, so there are some specific signs of low calcium that we can see on the patient. So here are the two signs. So this first one, what we're doing is we're tapping on the facial nerve just in front of the external auditory meatus, and that would cause twitching of all of the muscles on that side because it's going to stimulate the facial nerve. This is called Schwazdeck's sign. I don't expect you to remember that, but just know it's a thing. And that's how you do it. The other one is when you inflate the blood pressure cuff, the patient starts to squeeze their hand and then it contracts. And this usually happens after a few minutes of squeezing the blood pressure cuff. And this is called Trousseau's sign. And this would also be another indication of low calcium. So how does this apply for us? Well, you're probably not going to be tapping on people's facial nerve, but you are going to be getting blood pressures. And if you see that that blood pressure is causing the patient's hand to cramp, you might think, let's check a calcium. So that would be a time where you would say, paramedic discretion, go ahead and check the calcium level. What you'll notice is that a lot of these symptoms, paresthesias, periorbital paresthesias, carpal pedal spasms, right? They have a lot of overlap with hyperventilation and a panic attack. Now, what actually happens is that when you are having a panic attack, you're hyperventilating, you're breathing out a lot of CO2. CO2 is equivalent to acid, so you're breathing out all your acid and you make your blood more alkalotic. That alkalotic shift actually causes your calcium level to drop and causes all the same symptoms of hypocalcemia. Now, the nice thing is that you start to breathe normal, it's a transient hypocalcemia, and then your calcium level comes back up to the same level again. But if you've noticed that there's a lot of crossover between anxiety or panic attack and true hypocalcemia, it's actually because they are the same thing. It ends in the same low calcium level in the blood. All right, moving on to hemoglobin. So When we talk about hemoglobin, we're talking about anemia, right? So when hemoglobin is too low, we call that anemia. And what kind of symptoms? Well, we know that hemoglobin transports oxygen to the tissues. It's our oxygen carrying molecule. And so we might feel fatigue because we don't have enough oxygen to get enough energy to do our daily processes. We might also be short of breath for obvious reasons. All right, so what are some causes? Well, heavy vaginal bleeding, GI bleeding, or of course, either internal or external traumatic hemorrhage. All right, so treatment. The protocol states only in cardiac arrest if you check the hemoglobin and it's less than 5.0 grams per deciliter, and the patient is in any rhythm except asystole. This is basically meaning if they're in PEA, then go ahead and give a blood transfusion. Of course, if we don't have blood, we won't give blood, but sometimes we might be able to make sense of why a patient is feeling fatigued, especially, childbearing female, heavy vaginal bleeding. They're complaining of fatigue and shortness of breath. We might say, oh yeah, it's because your hemoglobin is very low. All right, last one. We're going to move on to lactate. Home stretch here. All right, so lactate we're going to use if we suspect sepsis. All right, so what is sepsis? Well, guess what? We got a protocol for it. So the best EMS adult sepsis alert criteria, remember, you got to go down the checklist. So you have to think about, do you have a source of infection, right? So look down this list here. And then step two, one of the criteria is the lactate elevated? So how elevated? Well, greater than 2.0 millimoles per liter. That would indicate severe sepsis. If it was greater than 4.0, that might indicate septic shock. So what would be the treatment if we have a patient who has sepsis? Well, of course, we're going to give fluids and we're going to give push dose epi if our blood pressure gets too low. And then we're going to consider giving antibiotics. And which antibiotic would we give? Well, we got a protocol for that. We give cefepime, and they have to meet the latch criteria. And you can see that if you have two or more of the latch criteria, and lactate being one of them, you can go ahead and give pre-hospital antibiotics, cefepime. All right, so what are some pitfalls we can run into when doing a lactate, when doing the labs for lactate? Well, we do have some false positives. In fact, there's quite a few false positives for lactate. So what is a false positive? It's when the lactate is elevated, but it's not sepsis. Remember, not every lactate elevation means sepsis, but it can mean sepsis. All right, what if a patient had a seizure? Yeah, they're going to undergo anaerobic metabolism and produce a lot of lactate. Just like if you were to exercise, you could get your lactate up pretty high. Major traumas, because of lack of blood flow, the patient is going to have a high lactate. A cirrhotic patient, chronic liver disease, is going to have a high lactate at baseline. Also, if patient's very dehydrated, has alcoholism, or patients taking metformin for reasons we won't go into, they can also have high lactate. So what does a high lactate actually mean? It means that they're undergoing anaerobic metabolism. And just as a review, we know that oxygen is necessary to combine with carbohydrates to produce ATP and CO2. And this is basically metabolism, right? So if you have oxygen, that's called aerobic metabolism. But if you don't have enough oxygen, we use anaerobic metabolism. Anaerobic metabolism is oxygen poor, or you don't have enough oxygen because you're exerting so much. And so we produce ATP, but it's less efficient than aerobic, and it also produces lactate. So anaerobic metabolism produces lactate. All right. So if you have any questions, please email, text Captain Brooks or myself. Remember that the EPOC operations will be covered as a separate lecture. And additionally, thank you for what you do.